we may have a few more people joining throughout the next few minutes, but we wanted to get started. We have a very, very packed session today. 4 different speakers presenting on different approaches that they have taken to the community connector concept and supporting people at end of life and broader. So just quickly, I'm Bonnie Tompkins. I work at Palliative Canada, and I am also a council member for Public Health Palliative Care. And I just wanted to share a few things about our presenters today before we sort of jump into it. So first presenter will be Barb Fasut. I hope I said that correctly. She will be presenting on the Nav-CARE program here in Canada, and she's a professor at the School of Nursing at the University of British Columbia, and also the principal research chair for palliative and end-of-life care in Canada. The next presenter will be Jessie Williams, and she will be presenting on a concept in Australia that sort of has 2 folds to it. One that is a train the trainer concept, and then also a community connector program as well. And so she's the community program manager at Community Care and Wellbeing, which is a large health and community service organization in Sydney. Its purpose is to enable individuals and communities to grow, connect, and feel supported through collective expertise. She was also a part of the National Champions Committee for Palliative Care in Australia. The next person we have is out of Colombia, and is Camila Renderos. Again, hope I said that correctly. And she's the executive director at a foundation, Clarity, but she can clarify for us. So she'll be here speaking today about her community connector program that they have in Colombia, and I believe is also in the US. And then our last presenter is Dr. Julian Abel. He is the director of Compassionate Communities UK and has run projects local, regionally, nationally, and I would say internationally. He is also the past vice president of Public Health Palliative Care International. Okay, let's get started. So I just want to take a second for myself to do a territorial honoring. I know some of the other presenters may do them during their sections, but I really wanted to take the time to acknowledge the land that I'm currently presenting from today, which is here in the city of Ottawa, and that is the traditional unceded territory of the Algonquin Anishinaabe. And also, I'd like to recognize the land that I was born on in New Brunswick, which is the unceded territory of the Wabanaki people. Next slide, please. So just a little bit about the Palliative Care Echo Project, because Public Health Palliative Care and the Palliative Care Echo Project, we are co-hosting this with you today. So the Palliative Care Echo Project is a 5-year national initiative here in Canada that's focused on cultivating communities of practice to establish continual professional development among healthcare professionals, but also among community members, hence our session today, and really focusing on patients who are dealing with life-limiting illnesses. So if you'd like to learn more, certainly you can check us out. Also, we'd like to acknowledge the financial contribution of Health Canada as well, because they help support this program. Next slide, please. So we've sort of introduced ourselves, so we'll move along to the next slide. And just wanted to take a minute to share any conflicts of interest. So certainly I work at Pallium, and I also sit on the council for PHPCI. So I certainly like to share that. But our presenters have not noted any conflicts of interest. Pallium Canada itself is a charitable organization, partially funded by Health Canada. And we also generate funds from participation fees in our courses, such as our healthcare courses. Next slide, please. So a few little welcome pieces and reminders. So if you want to make a comment, we please ask you to use the chat function to do that. If you need any help, we have some great ECHO support staff online with us to help out with that. But when we get near the end, so we're going to hold all our questions to the end, we'd love you to put them in the Q&A function. So that way it's just sort of easy for me to go through and make sure we get all your questions. So chatting, use the chat function, maybe let us know where you're from right now. And then when it comes time for that questions period, if you could just put them in the Q&A function. And just a reminder, this session is being recorded. So you will receive a recording and a copy of the slide deck, but we also mention that to remind you not to share sort of any personal information. Next slide, please. And as I already alluded to, this is a partnership, this session, this webinar. So we are co-hosting between Palliative Care ECHO through Pallium and then Public Health Palliative Care International. Next slide, please. Just quickly, if you don't know who Public Health Palliative Care is, here's just some of our aims. We have been around for quite a few years, and maybe Julian, you may want to jump in and tell me just how many, but I know for sure over 10. And really the focus is on sort of ground up approaches to supporting people who are on a palliative care journey. So that means caregivers, that means people who are grieving, and certainly the patients as well. And, you know, how they, the concepts that are nurtured very much follow the public health charter. And so looking at promotion of health, right? Education practices. And then we sort of do that through these webinars. We have a conference every 2 years. Publishing research and things like that. So we try to really foster the compassionate communities movement, for instance, and much more around the world. Next slide, please. All right, I'm going to hand it over. So over to you, Barb.
Well, thank you, Bonnie, for that introduction and for the privilege of being here today. I would also like to do a land acknowledgement. I live and work on the unceded territory of the Syilx people. So Bonnie has organized us brilliantly. She's given us a set of questions to answer about our program. And I'm going to stick to my 10 minutes, so I'm going to jump right in here. But I have given you some contact information here on the first slide, just in case you want to contact us after the presentation. Well, I'm getting over enthusiastic here. Okay, so the Nav-CARE program provides specially trained, mentored, and experienced volunteer navigators to work with persons living with declining health and their families in the home to improve quality of life. And so some of the key principles of the Nav-CARE program is it really is about quality of life. So oftentimes when people hear about navigation, they think about healthcare navigation. This program is really about quality of life navigation. So it's trying to address sort of the social determinants of health that happen alongside declining health. And we have also sort of 4 principles that we're really trying to reach in terms of public health policy in Canada. And one is to provide early support. So we try to connect volunteers with clients early in their trajectory. We're really trying to build volunteer capacity. We have this marvelous generosity of volunteers in Canada. So it's really about building that capacity and mentoring those volunteers. It's about optimizing access to resources. We learned in some early studies, particularly in rural palliative care, that there were just all kinds of hidden resources that people didn't know about. And so one of the goals is really to link people to the resources that do exist. And of course, in keeping with the compassionate community movement, all about building social connections. So I would call this sort of a model of a compassionate community intervention. One of the questions was how long we've been going. I confess we've been at this, feels like forever. Really, Dr. Wendy Duggleby and I, probably over a decade. It really began with some rural ethnographies in terms of trying to understand what rural people in Canada wanted and needed. We moved on to some pilot studies, some knowledge translation studies. And so a full decade later, we're now actually doing some scaling up and sustaining. And there is actually a nice little link on the web there where we do talk about our stories and what we learned at each stage of the research. So we've been at it for a while. And of course, we've been at it for a while because we've had absolutely marvelous funders. And so one of the questions, that came up is how is this program funded? And generally, we've managed to get some sort of research funding to get people started. Something's gone into my thing here. It's going ahead on me. To get our research started, but then the idea is that the program would be sustainable after the program gets started. And so with a generous contribution from Health Canada, you can see that we're now scaling out using a hub and a spoke model across Canada. We have quite heavy intensity within BC and Alberta, a few in the prairie provinces, some in Ontario, and now we've actually gone to Newfoundland. A really exciting recent development is, along with our colleagues in Belgium, we received some money from EU Navigate. And we now have 6 European countries that are adapting Nav-CARE to their context and running a randomized control trial to do effectiveness. So that just started this year, and we're very excited about that. This is so funny. These slides are on a timer and they're keeping me going, Bonnie. So, so who does Nav-CARE serve? Really persons facing loss and declining health. Persons experiencing complex treatments and decisions, people who feel lonely or socially isolated. They could be living in urban, rural, or remote contexts, at home in long-term care or assisted living, but the key is that they're living with declining health. And in particular, we have a new program. Again, thank you to Health Canada in that we've created an adaptation of family caregivers of persons living with dementia. So that will be added to the Nav-CARE competency training. So how are people referred? Primarily through self-referral or through family and friends, can be through healthcare providers, but really the vast majority have been self-referral or through family and friends. And I would say referrals has been probably one of the trickiest pieces of Nav-CARE. It's getting the volunteers connected to the people who need their services. And I'm sure those of you who have worked in volunteer programs know that that's probably a tricky piece for many of them. So who are our volunteers? As I mentioned, they are experienced volunteers. So in our most recent study, the average age was 63. They were predominantly female, and fully 50% have greater than 10 years of related volunteer experience. We asked them to commit about 1 to 2 hours per week, and then they're managed through a volunteer coordinator. So we only implement Nav-CARE through an organization that has some capacity, and the most important capacity is this volunteer coordinator. And then Dr. Gloria Praveen puts the coordinators together in what she calls hub huddles for support. And so the people from across Canada meet together in a community of practice to share experiences. How do we prepare our volunteers? We have online training in both English and in French. It's 6 modules, usually takes about 6 hours. We also have sort of in-person training materials if people prefer to do it that way. But basically the volunteers learn how to address quality of life concerns, how to advocate, how to facilitate community connections, how to promote active engagement, and how to support virtual navigation. We added this final module after COVID and thought, you know what, we need to find ways to reach out. And certainly in Canada with such a remote population, we need to do that as well. So what do Nav-CARE volunteers do? They visit in the home every 1 to 2 weeks. It's a long relationship. They develop relationships with persons. It's first and foremost a relationally oriented model. They have the time really to hear stories, to share a cup of tea or to take a walk. And some of our participants often say, you know, the client or the volunteer brings community to me. In the context of that relationship, they assist with tasks that persons with declining health find challenging to navigate, whether that's transportation or living arrangements, pet care, whatever that might be. But they don't necessarily do it for them. They help them find the resources and local services to help persons meet their daily needs. They do a lot of listening. Anybody that's living with declining health has a whole list of decisions to be made. So they're very good listeners, sounding boards. And probably most importantly, they provide a safety net for people living at home and without family nearby. So because they stay very close in touch with these individuals, that thing that we often see in healthcare is that people show up when really something has happened. It's crisis management, and the volunteers really stay in touch and are that safety net when they see things start to go sideways. In terms of implementation, we have a toolkit that includes all kinds of resources. Basically, you pick it up and it's everything you need to implement Nav-CARE. I did mention there is the online training in French and English. There's 4 manuals that come. One is an implementation manual for organizations to figure out, is this a good fit for us? How do we do it? There's a volunteer coordinator manual for the person that leads the program. There's a training facilitator's guide to complement the online training. So all kinds of exercises to do in person. And then of course, a volunteer navigation training learning manual. And so that's free of charge. People just need to contact us and sign a memorandum of agreement, which only says we won't change the intervention in any significant way without consulting with the team. And you won't take money for it. That's the other thing, because it has been funded by public money. Over a series of studies, as you saw, we've done a whole number. The impact has been fairly consistent. Clients show statistically significant improvements in awareness of available services, their confidence in making decisions, taking care of their illness, and communicating their needs to healthcare providers. And they generally rate the service really important to their care, and they can actually cite very tangible improvements in quality of life. Volunteers are very satisfied and feel competent as long as they get connected early, and stakeholders feel that it's well designed, but it does require some key organizational things, which is the last thing I'm going to touch on. And this is really our learning to date over multiple implementation studies, is that these are sort of the 4 factors upon which Nav-CARE will either succeed or not. And one is organizational capacity. The organization really needs to have a good reputation in the community, a good funding model, and a strong volunteer pool. Needs really strong leadership because you're shepherding a new program, so it needs a program champion and some stability over that champion in the early periods. Really clear identification of a client population. In urban areas, groups that serve this population, there are often many of them. And so there's some inherent competitiveness. So, people need to really kind of focus on what is my population in this community and make sure there's no overlap or competition, and certainly some collaboration among the many organizations. And finally, messaging, really some clarity around the value added of the program. In some cases, the avoidance of hospice palliative language, because we're going upstream and these people often don't see themselves as palliative clients. And then some targeted strategies for reaching isolated populations, because of course that's who we're concerned about, right? The people that are disconnected. And so in recruiting them, you need to find kind of innovative ways of connecting them to the program. It's really an option for organizations that have well-developed mechanisms to support volunteers. Volunteers are willing to dedicate some time, some degree of integration with health and community resources, a champion, and probably most importantly, some adaptations that suit your community. And so there is sort of a core of Nav-CARE, but there are also some adaptations that you can make to make it best suited to your community. So thank you very much. I'll look forward to the conversation and to hearing about the rest of the programs.
Thank you, Barb. All right, thank you. So up next, we have Jessie to speak about the work from Australia.
Good morning from Sydney, Australia. It's just over 6 a.m. here. And thank you so much, Barb. That was fascinating. I got so much out of that. I want to start by acknowledging country. I'm going to do a slightly longer one because we've got a referendum in this country to look at our constitution. So it's a very particular time in history for us. I acknowledge that I live on land that crosses over unceded First Nations country. I pay my respects and give thanks to the ancestors, elders, and young people of the Gadigal land for their nurturing, protection, and caregiving of these sacred lands and waterways, acknowledging their continuation of cultural, spiritual, and educational practices. I am grateful for the sharing of country and the renewal that country gives us. I acknowledge and express sorrow that this sharing has come at a personal, spiritual, and cultural cost to the well-being of First Nations people. So thank you for having me here today. Bonnie, you're going to time me. I'm going to jump right in. Let's move to the next slide. Okay, so I thought I'd start with a snapshot. So the underpinning goal for the program that I'm going to talk about today is always for us to build capacity in the health system to uptake a version of a community connector model. Our funders for this program have been the primary health networks. We've worked with multiple over the years. In Australia, essentially our primary health networks, or PHNs, are our government mechanism to improve patients' care and to coordinate different parts of the health system. And essentially they commission health services. So we've worked with 2 to 3 different primary health networks, basically in the northeast of Australia, in the Queensland state. And for this program, we worked with 2 different funders over time periods of a range between 4 and 6 months. So you'll notice, as compared to Barb, this is a very short time frame to do some work, and that kind of sets a bit of a context, I think, for the program. So what did we deliver in 4 to 6 months? Well, we delivered a Train the Trainer workshop, which is going to be the focus of this presentation. We delivered some community of practice sessions, so ongoing online conversations with people who came through the workshop. We delivered death literacy education. Now, we sometimes did that as a standalone. Sometimes we wove some of that content into the Train the Trainer. We developed web-based resources so that people could download tools and have them ongoing access. We also did a lot of local health promotion with our health partners. So sometimes we would have to, jump on local radio or do local newspaper interviews to highlight some local stories there. And lastly, wherever possible, we developed some sort of prototypes for future health partnerships models to support the training and resourcing ongoing. One of the reasons why 4 to 6 months was such a small time frame was it's often at the end of a financial year when there's an unspent grant that we can kind of go in and say, hey, got $40,000 lying around, why don't we do something together? So we're always trying to, as I say, build capacity there. So how did we get the start for our model? Well, we learned from Mendib, amazing. And I know that Julian Abel is going to be talking a lot more about that in his presentation. So we did some piloting back in 2018. So many of our connector programs have been delivered through COVID. So there's been, the word pivot has been used multiple times. The latest phase for us has been from 2021 onwards. So for this latest iteration of training, how did we get our start? Well, firstly, we were invited to present to regional health interagencies on the compassionate communities approach. These presentations took a lot of time, a lot of effort, but we always felt it was really important to start with the basics of orientation. Next, we were able to identify the champions. So in those interagencies were palliative care physicians, GPs, nurses, who had gone, compassionate communities, I've heard of that. That rings a bell. And so it was those champions that were able to then go back to their health network meetings and say, yeah, let's, this is important, let's do something. And then we proposed a plan based on the budget available. So in those plans that we developed, we're always trying to do the following things. We're always trying to establish a case for support for future funding. We're always trying to leave participants with tools that they can use as community members or health professionals without that reliance on ongoing funding, and tools that they could duplicate. We always wanted to tap into the natural motivations of people, enlivened to social connection, always going back to that champion model, because momentum is always so important in community development. Leaving participants with increased death literacy at the very least. There's no downside to increasing your death literacy. And programs that, built networks locally, regionally, and in some cases nationally, always looking for building networks. And lastly, addressing where possible what the research says about health and community networks. So we've all got some amazing research that we can draw on, which looks at some of the barriers and some of the strengths of this work. So the main audience for the Connector training are community-minded individuals and people who are passionate about engaging with community members on identifying and signposting supports that either formally or informally address end of life. And signposting is such a powerful word because I think it's quite a disruptive word as compared to, referrals, for example. They were health individuals or community individuals, and quite often they were retired health professionals. That seemed to be a really strong theme for people who came into our training. A lot of single older women, as I recall, from some of the trainings that I ran. This training was not designed for those working directly for families. So the Connector trainings essentially were for active citizens who informed other locals on how to access supports. So what we did was we defined this role of a lead connector. So it's a game changer if you've got thousands of people who can be active citizens and connecting people to local supports. But, basic sustainability principle says, well, how do we do train the trainer? How do we actually empower those people who are those small L leaders who are really passionate about giving their time? So the role of a lead connector is to coordinate the community connector programs. They are facilitating those regular meetups just in cafes and coffee shops and libraries to talk with people. They're always on the lookout for recruitment. They're always on the lookout for venues and community partners to host the workshops. Where there is a assets directory, more about that later, they may verify the contact details to make sure that that directory is up to date. And certainly they want to collect and share the evidence of participation and impact. They may deliver as part of a paid role or as a volunteer. So we had people in the Train the Trainer workshops who were palliative care staff who went back to their management and said, could I just have half a day a week to be this lead connector role? And for others, they were just 100% retired volunteers. The beauty of this approach in terms of this Train the Trainer, especially when it came to working in small regional towns in Queensland and Australia, was that, people knew each other in the room. They were like, oh, hi, John, I saw you last week at the bolo, And so we were able to go through the 3.5-hour workshop, but at the end, we're able to say, so what do you guys want to do about this? Who's going to be a lead connector? Who's going to be a community connector? And who's just going to stand on the sidelines and go team? So it was a hyper-local conversation. The leads were supported by the community engagement officer in health. So at every step of the way, it was health and community together. So by that, I mean, staff from my team would work with the community engagement officer from the primary health network. We would co-facilitate, and that community engagement officer would be the one who would be coordinating overall. So that hopefully when the training was finished, the health system could really run with it. So you always know there's a community connector workshop when you see billions of post-it notes. So what people do with the post-it notes is when we bring people together, we ask them, so where do we give and receive support in this town? And what are the relevant services and organizations? And everybody just crazy brainstorms, and then we gather them and group them together, and then we sort of give them some themes, and then we step back. And it's really quite a transformational moment when you go, holy moly, I didn't realize that there's all this information out there, and how privileged are we to be in this room and to know this stuff. And if only everyone knew it, and that creates the momentum. That's when people walk out of the room and go, okay, I'm on a mission. So we ran over the 2 funded 4 to 6 month projects. We ran 18 workshops. Each workshop goes for 3.5 hours. We got through about 300 attendees overall. Each group was between 7 and 25. All the promotion, the advertising, the recruitment was all done by the health service. At the end of the training, we, put the leadership call. Okay, so who's up for this? No pressure. And it was perfectly fine if people didn't want to take on that lead connector role. They still got something out of it, and they were at the very least champions, or their death literacy hopefully had increased. So what was in the agenda? Bonnie, how am I going for time? 5 minutes. Okay, good. What was in the agenda? What did we cover in the 3.5 hours? Okay, so first principles. What are compassionate communities? The 95% rule. That's always, when you had a lot of health people in the room, that's always an eye-opener. What is death literacy? And especially we would lean into the community knowledge aspect of death literacy, because that fits really nicely with the connector model. So people would automatically start collectivizing their knowledge. We would talk about the role, of course, of the lead community connector. We would introduce this idea of asset-based community development. We tried to stay away from lingo. I'm using it now. It's hard to stay away from lingo, and rather come back to some simple language, like, for example, head, heart, and hands. What do we know? What do we feel? What can we do? Those sorts of language constructs. How do we hold a connector workshop? So they would get a manual, and it's a really good, robust manual. We're talking like 40 pages with images and worksheets and case studies and sample agendas, sample acknowledgement of country. For many people, they didn't know how to acknowledge country. So it was about walking them through it, having them experience it, and then reflecting on how they would do that activity slightly differently. We wanted the lead connectors to really bring their own flavor in there. How do we recruit participants? Logistics, outline, and next steps, of course. Okay, let's jump on to the next one. So just 2 snapshots of the evaluations, which I've just themed them here as best I could. Like the number one was, so what's the most impact for people? It was the open-hearted sharing, the knowledge offered and received, and a room full of compassion. It's so powerful to invite adults to share what they know. I remember a woman came into one of the workshops in a small town called Gympie, which takes about 3 hours to get to from the main city, I think. And she said, I didn't know this was anything to do about grief. I just saw the word connector. And for her, she was, she wasn't sure if she wanted to stay because her husband had died a year earlier. And so we just had a little sidebar, and she decided to stay. And whilst it was a kind of disruptive moment for her in the beginning, she said she felt like she found her tribe by the end of it. So, it's always tricky when you're advertising these things, what words to use. You don't want to badly manage people's expectations. But I find, because of the heart of the work, when you've got people in the room, it's all okay. Everything becomes okay. The amount of connections I did not know about. Changes have to become available in the community. So there's a real passion there for change. And obviously the clarifying of the tools and the processes, identifying what signposting is, was always a really powerful learning moment for people. So we asked, what else might you do after this workshop to strengthen your local compassionate community? So many ideas, just reams and reams and reams of paper. Some of them are volunteer to get a community directory together. So we ran these workshops without a community directory. We did try our best to work with our health partners, to the point where we were talking with their IT units about how to build web pages. We came up with a list of tags that they could use for their directory. But without the funding and without the buy-in, it just wasn't possible. So in some cases, we would set up like a Google open source spreadsheet for the community to just use. But I think that was I'm not sure if it was a failure, but it was just something that we didn't really progress very well. So we left people hungry. They wanted a directory. Increase my understanding of end-of-life support so they can have more informed conversations. A little bit of knowledge is a good thing when it comes to community connectors, because death literacy, of course, is about, learning how to find out that information yourself. So some of the challenges, a lack of clarity with our health partners on what the ecosystem is in which the workshops take place. In Australia, we've got a federal system, but our health budgets are managed by state. And then we've also got local. So we've got 3 levels of government, and we've also got long distances between towns and a whole lot of mismatch of other things. So quite often it was like, so how do we draw a geographical boundary around this? And what health boundaries do we use, if at all? Because people don't relate to health boundaries, they relate to town names that they relate to. So that was a bit complex. To what extent should the messaging be adapted for the different audiences? So, do we adapt it for community leaders or health professionals, local council members, for example? it's all very fine and well to say everyone's welcome, but that's not always empowering for everybody. And who will be responsible for those follow-up actions? So with short-term projects, short-term funding, we always try, as I said, in those first principles, to give the tools that people can just use. They don't have to ask for permission to run a workshop. But lead connectors need supporting, and they need that community of practice to be ongoing. Okay. I want to say a word here on, sorry, I'll just go back. One last, it's not so much a challenge, I think it's more of a learning, is staying at the table with health partners, staying at the table and moving at the speed of trust was the most important thing for us here. And you always think you're going to go to a certain direction and you end up going in that direction. And I think it's fine, because if you stay at the table and you've always got that trust, what I found is that quite often the staff that we worked with and our health partners would obviously move on into different roles in the health system, and then they would be the champions for the program, and they would call us another year later and say, hey, let's go and do it over here, and let's build on the learnings that we had. So relationships are absolutely critical. So what's next for us? So we're designing the next phase for our community connector model in our own heartland in Sydney's north. As Bonnie mentioned, CCNB, where I work, we've got a large region of about 500,000 people in Sydney's north. And so we've got some integrated health partners there. As an organisation, we deliver health services. We also do community programs, and we also have a foundation. So we're opening up a small grants round for other organisations that want to partner with us in this model. And we're hoping that those small grants can help shine a light on the issue and also support other programs that are part of our ecosystem. Our door is open for delivering the Train the Trainer workshops, this lead connectors, community connector training for other place-based programs. That special source of connector training is incredibly powerful. And of course, regional and national partnerships to grow and learn. Always love to chat. So thank you so much for the opportunity. I hope I made sense. It's very early here. Lots of love. Okay, bye.
Thank you, Jessie. Yes, it is 6 a.m. her time, so she has been great to participate. Okay, next slide, please. Okay, so we're turning it over to Camila. Thank you.
Thank you, Bonnie. Thank you, everyone. Really happy to be here as well, sharing. So I am based in Colombia right now. I'm originally from Colombia, and I represent two organizations, so Fundación Keralty and Keralty Compassionate Communities. We are part of a healthcare organization that implements worldwide. We have insurance companies, primary care, hospitals, university, nonprofits, which are the ones that I represent. And the reason that we have such a wide array of organizations is because we truly think that health care doesn't come with only doing the clinical side of it, and that we have to understand the person as a whole. And so part of the job description that comes with the work I do is to help transform the way we as a company do, healthcare, and connect to communities and connect to our patients, but also to help, transform the conversation around caring for others and involving others. Next. And so we work on a twofold strategy. We work, as I was saying, transforming healthcare and empowering communities. So I'm going to talk a little bit first about what we do on transforming healthcare and how we work with the healthcare sector so that we can sort of match what we want to do on the other side. Next. So as I was saying, we work this, right now we're doing it in Colombia and in Florida with healthcare services. We work in primary care facilities, that would be both in Colombia and in Florida. We work with hospitals, both in Colombia and in Florida. And then in Colombia, we have been working with palliative care for quite a few years as well to transform the way we're connecting to our patients and the needs that they have. we work with different kind of settings, and therefore we work with different types of methodologies. So for example, in the palliative care setting, we've been using the Todos Contigo methodology from the New Health in Spain. For the community basis, we've done methodologies around social capital building and compassionate networks. And in the clinical setting, we have worked a lot with Julian Abel and their experience from and learning a lot to how to do it there. Next. One of the first things that we do is that we make sure that all of the healthcare services are identifying, what are the true needs of our patients and how we can connect for them, and that changing a little bit of the mindset within the healthcare sector. So we want to get the doctors to talk differently. And when I say doctors, it's not just them, but the thing is that I would say that's where we have the biggest challenge, to get the doctor to, look beyond the exams or the blood pressure or the H1AC and all of those things, and sort of widen the scope. And so we have been using different tools depending on where we are. So we do Lubin scales for loneliness, and that we've done a lot around palliative care, but also seniors. We use circles of care, especially in palliative care, so we understand who's around and who's helping in the caring process. And then we do SDOH screenings when we work with communities that are more underserved, where we understand that if you don't have access to food, it might be hard for us to be asking you to do other things. So we want to make sure that we're also understanding that. We work in a partnership. We have community health workers. Oh, you went one ahead. Sorry. Can you go back one? Go all the way back to the previous one. Sorry. I can't move them. There you go. We can stay there. So you can stay there. So we work with community health workers who are currently constantly on the ground and identifying the resources that we can connect. And they identify, official resources like formal resources, social services on the ground, but also community-based resources. So, community organizations, the group of men that meet at a corner to play domino, the group of women that, knit together at this coffee shop. So we understand sort of the informal and formal things that are happening on the ground. And we also identify those people that we would call connectors, that are just people that are, able to point us the right way in terms of what other things are there, but that could also point the right way anyone in their community as we, start working in this, whole approach in terms of a network that we want to create on the different, and that's why we work at the, healthcare side, but also on the community side. Our community health workers are constantly identifying, those resources, and then the patients that get identified by the providers or the doctors around one of the needs, they get a social prescription or a connection to something else. So they could get connected directly to a resource. They can get connected to a community health worker in case they need, that extra help, or they can get connected to a methodology that we have that's called Communities of Wellbeing, that we actually worked with Julian Abel as well, in terms of working around what he calls the 6 jewels of health, where it's more of a peer support group where we talk about, the things you might need. It's a very open conversation. It's not led professionally by anyone in terms of, giving a lecture of what's the healthy thing to eat. It's more about how we all can find solutions to our challenges. And then from there, we just start connecting and, of course, measuring the impacts that we have. We have volunteers that we constantly identify, volunteers that are part of the patients from our community, our medical centers, but also volunteers just in general in the community that want to do something different and that want to connect differently. One of the things that has been wonderful in the last, few years is that we started working a lot with seniors in those volunteering programs, and we found that they were really happy to be taken into account. Especially, seniors are seeing like, something that's a bother, right? They're old and they're just there. And then bringing them in and making them, the key actor, that they're bringing their knowledge. So we have a historian that likes to teach history classes for people who just want to come and listen to him. And so they ask questions and they post new topics that they want to do. And so they feel also very valued. And that has been one of the amazing things that we've had happen in the last couple of years, especially after COVID, where I think seniors were one of the one that got hit the hardest. In Colombia during COVID, we had a full lockdown for 6 months. No one could go out. And seniors were longer. Seniors and children, oddly enough, were locked down for a longer time. And so we try to do a lot of those things virtually to try to get seniors and children, especially seniors, connected to something different. And so after COVID, we tried to keep that up because we felt that they were really, hit after being locked up for such a long time. Next. And so on the other hand, we work with our compassionate communities of care, which are what we try to do on the ground, and so that we can try to change, what happens and sort of match that other side of the story. And so we promote the creation of those compassionate communities and cities that can learn how to care for each other and how to promote compassion and support and solidarity. And so we have done this in what we do is try to identify leaders within the different communities where we work, that we train with a partnership that we have with the university here in Colombia. It's a free training process for any one of the leaders that we identify. And they learn tools and strategies around community development, networks of care, participatory methodologies. They're already leaders on the ground. They just need sometimes that extra info on how to do it on the ground. And so what we work with them is so that they can start connecting with communities. But we also make sure that we're connecting the healthcare services and other organizations so that we do that match. So that when someone identifies at that healthcare or another organization level, someone that needs something, they can connect them back to that community that has become empowered and that understands how they can work together and connect other people. Right now, we have this process happening in, you can move ahead two clicks. There you go. Yeah, go ahead. We have this in 7 cities in Colombia. And so if anyone is interested in depth of the cities, I will share them on the chat. We've reached around 13,000 people that have improved their networks of support. And we know that they have gone from around having 1 person around them to having 4 people around them. And this comes not just from, volunteers or connectors or just their community, but also about engaging the family. Because we find a lot of times, and this is especially in palliative care, we find a lot of times that even family pulls out in terms of the caring process and you have 1 primary caretaker. And so we've also talked, Colombia is still a very, family-oriented setting. People live in the same city. They might even live in the same neighborhood, yet you don't find them, getting involved. So we've worked a lot on how to increase that involvement, not just from volunteers or connectors or just general community, but their own family. We've reached 111 expert volunteers, and these are people that want to share their knowledge around things that could be of support. So around grieving, around caring for patients, around self-caring, both for patients and the primary caretakers. And so we do different type of topics here, depending on the things we've done. We identify that people need. So we've done from mindfulness to how to care for a patient that's bedridden. We have 35 organizations that we have partnerships with that can bring things forth and support the communities that we work with. And we currently have 20 communities of care, which would be sort of our biggest, I would say that's where most of our efforts are going right now, because this is at more of a local level. We're trying to reach directly neighborhoods, like smaller sections of the city. So Colombia is made up of really big cities. And so changing the whole city is very different, but you can change 1 neighborhood at a time. And so we started going through different neighborhoods, connecting those leaders that we do train, and then inviting others to participate. We have 820 people currently participating in those communities of care. And when those are the ones that are participating actively, and they might be impacting other people that are within their community setting. Some of the pictures that you see there are from the community doing a mapping of their own resources in the community, the mapping of the needs in their community, and how they can get organized to support each other. So for example, in Santa Marta, one of the cities where we are, when they did the canvas of their community, they identified that they had a lot of seniors that were lonely and they didn't even know. And so they labeled each door, I think it was with a heart. And so now they know. And then when someone's coming back from work, if they're coming 10 minutes early, they'll knock at that door that has a heart and just stop by for a quick chat. And so sort of sit there and be with them for a while. When they do the community meetings, they do them at one of the houses that has a heart so that they feel involved as well. And usually those seniors might be someone that has more struggle moving or has some sort of disability. And so that allows them to keep being involved without them having to constantly be moving. And we have a ton of examples around of that. We've also started working within jail settings, and we've done in a jail setting with seniors, not high risk, not high offenders, of course, but that we feel that also, deserve that creation of those compassionate communities. Next. In terms of and I switched the slides, but in terms of what we have achieved at the clinical setting, and it was my fault that they got switched. In Florida, for example, we've reached this year, this first semester, 4,200 seniors with Lubin scale. So Lubin is the scale that we use for loneliness. And we've identified 1,084 seniors as lonely. And before we started doing this, none of our doctors knew that they were this way. And it's funny because sometimes when the number pops up on their screen and they realize that the patient is lonely, they realize that that might be why their patient was not meeting their goals or doing what they expected them to do. And the thing is, if you're lonely, can be hard. 45% of those seniors got a social prescription directly from their doctor, which is the ideal world. But around 90% of those seniors that got identified as lonely got connected somehow, because our community health workers anyway go back and check to make sure that anyone that scored low in the Lubin scale, they can make sure that they get connected. In Colombia, we have 27 medical centers throughout the country participating. We have around 40,000 scales done. And then we've also connected a bunch of people. And this one, we've actually managed to measure the cost reduction in terms of hospital stays. So we also know that this is not just good, but it's also good in terms of, economic numbers. Next one. You can just go ahead. And so some of our main challenges, I've divided them in two. So within the medical center settings, next. But you can go all the way. So within the medical center settings, I would say that some of the biggest struggles is actually getting the clinical side to understand that we need to include those scales and do a different approach, and not just measure, blood pressure, but also other issues like loneliness or SDOH. And then from there, understanding that they need to connect with that why, and that it's not just the responsibility of the community health worker, that this is something that we should all do, and that's why we have connectors, and that's why we have a database of resources that is available to everyone, and that if they want to do true healthcare, they really want to take care of their patient, they should do this as well. And then because of that, sometimes the traceability and measuring of the impact can be a huge challenge. And at the end, if you can show that this has the right numbers, you'll be able to get more people involved. And so for us, that has been. Within the communities, I would say one of our challenges is also breaking that connection. I think within the communities still think that health equals healthcare and the healthcare services, instead of just, my well-being and my health. And that we believe that health is in the community. And so changing that mindset, changing that you go to the doctor and you might not get prescribed this time a medication or an exam, that you're just getting referred to a resource in the community. That, spiked our complaints a lot at the beginning because people had a hard time understanding that. Building or rebuilding the social capital, so all of that trust within the connections of the community so that they can care for each other, so that they can put those little hearts in the door and people feel safe that someone's coming in to say hello to them. And that long-term commitment. Everyone that's on the ground, except the community health workers, of course, who are hired by the process, all of the other things, all of the communities of well-being, all of those pictures that you see right now there that are from different cities with different things that are happening are all led by people that are volunteers within the community that want to transform the way we do things. And so I what we want to do is sort of close that gap between what happens here at the clinical setting and then those communities that tend not to talk to each other and that should be talking to each other, so that we can truly connect the connectors of the communities with what's happening at our clinical settings, regardless if it's end of life or any other condition that you might have. Thank you.
Great. Thank you so much. So we're on to our last presenter, and we've got about 10 minutes or a little more left before we dive into chats. And so Julian, over to you. We've heard your work reference a few times already, so please share more.
Hi, everyone. I'm going to talk about something different, a little bit different. It's so great to hear these amazing, inspiring examples. And I thought it'd be worth just having a chat about what is all this stuff about? Why on earth does it work? And that's the kind of essence of what I'm going to talk about. And I'll keep an eye on the time so I don't talk too much. There are so many different terms for community connector and different roles and different ways of approaching it. So I kind of like the term citizen connector for what we have been doing in Froome and the way we're taking it forward in other places. And because it somehow captures the idea that citizen connector is something we all already do anyway. And a citizen connector, because we're all citizen connectors, and we're just people who know our community and help to create a warm-hearted environment, and are just prepared to listen. And really importantly, who wants to be fixed? Nobody wants to be fixed. So just thinking about people, if they hear something, celebrate it and offer solutions if people want them. There's a very big difference here in that citizen connectors are not volunteers. Volunteers are often people who step forward to do something. We're often thinking about this as being a natural part of people's lives, rather than just enhancing what people do quite naturally. And I always show this slide because this somehow captures it. This is a slide showing the impact of social relationships on mortality. And what you can see is that social relationships are more effective at reducing our risk of dying than giving up smoking, drinking, diet, exercise, and anything else you care to mention. Well, this is really curious. Why on earth does this happen? Because we think social relationships are a nice thing to have, but they're not fundamental. Wrong. They are fundamental. And why are they fundamental? Because the story that we have been told about evolution is some kind of British imperialist nightmare that's not very much to do with Darwin. And survival of the kindest is a much better description of evolution, especially human evolution, because we survive by being social. We lived in small groups of 25 to 100 people or more, and we were critically reliant and interdependent on each other. And so this is based in 600 million years of animal evolution, 2 million years of hominid evolution. And you find the consequences of this everywhere in our biochemistry, our physiology, our genomics, our behavior. It is incredible. It is incredible. I really liked the acknowledgement of the lands and the traditional landholders that we've been talking about, because somehow many indigenous peoples have not forgotten this. It's only us weirdos who've forgotten it. But actually the strength of community and interdependence is embedded in community life in indigenous peoples all around the world. Okay. I'm not going to talk about that because time is short. I love this quote from Bessel van der Kolk, and if anyone hasn't read The Body Keeps a Score, it's well worth a read. And I'm sure you can read it while I'm talking, but no doctor can write a prescription for friendship and love. These are complex and hard-earned capacities. And I would say that the language of compassionate communities is love and friendship and connection and interdependence. And when you look at what human beings are capable of, we're capable of remembering 5,000 faces, 1,500 names, 500 acquaintances. We are essentially social animals. We have evolved to be social. So all you're doing with the Citizen Connector is really making best use of our innate capacities. This is not doing something special, not training somebody to do something that's a mini professional. It's recognizing the fundamental importance of our qualities as human beings, our compassion and our kindness to the people around them. And that you can think that rather than thinking of individuals, you know, if you think about those 5,000 faces, 1,500 names, when you start mapping relationships, all of us live in this sea of compassion and kindness. Whether we see it or not is another matter, but it's so close to us, it happens all the time. It happens when a mother feeds their children first, when you open the door for somebody, or those moments when you first see your child or hold your child's hand, or those everyday activities that are deeply embedded in the roots of compassion and kindness. There's another really kind of critical bit of all of this is that we have a habit, especially a professional habit, of looking at maps of misery. Like we do this thing where we go, oh, this community lacks this, and great professional services can come in and sort the problem out, and look what a great thing we've done. But actually you can, when we, you know, we've been just talking about all the qualities that humans have. Draw treasure maps. All of those places where warm interactions between people take place. And when you look at your communities like that, you find the treasures everywhere. And I'm going to come back to that slide. But these are the treasures. This is places where interactions take place. Outside the school gate, skate parks, dog walks, sports clubs, model railway groups, GP surgeries, waiting area, coffee places at work, absolutely everywhere. And these are all potential treasures where friendship and warmth and connection can take place. And when that happens, this is a consequence of it, is that you start to see that you have these conversations and these connections. And on a really simple level, if you know about the treasures in your community, if these things are available as a resource directory, then, well, why not let the community know about it? And if the community know about it, if you do this short training session of maybe an hour, then in daily life, when you're listening to people, whether you're sat in a cafe or a receptionist or talking to a friend, if you think there's a piece of information that may be valuable, you can share it. Now, we know that community connectors on average talk about what's going on in their community about 20 times a year. In Frome, town of 28,000 people, over 1,000 people have been trained as community connectors. What this means is there are 20,000 conversations in a town of 28,000 people about how the community can support the community. This is incredible. This is a way of having a deep dive into a community, which you cannot achieve in any other way. You can't do this by social media. You can't do it by television. You can't do it by newspapers. And if you want a proof of this, look how COVID spread. It spread all around the world through face-to-face communication. And it's the most powerful way you can institute changes in a community. And what we find in Froome now, if you walk into a cafe or a bar or a restaurant or wherever, people are listening out for you. Froome has become known to be a friendly place. People are moving to Froome because it's known to be a friendly place. It's created a housing problem, one of the many problems that we have in the UK. So in the context of thinking about citizen connectors, then the heart essence of it is about being aware of the treasures in your community and making sure that there are a group of people who can share that information. And the kind of end of life bit, it's not too difficult to add on. In fact, if you start talking about death literacy and community treasures, if you start mapping out what's out there, you find there's an incredible amount of death literacy and experience. And it is about sharing that rather than thinking you need to somehow make something anew. So I'm not sure I'm going to talk that much. But there are some, I think I'm kind of about done because there's so much going on, and I think that's the essence of it. But it's really to say that the important bit of this is making use of the innate capacity of everyone to be kind and compassionate. You're muted, Bonnie.
Thank you. I thought I had unmuted myself classically. Thank you, Julian, for that piece. That was really great and so interesting to hear about, you know, the evolution of Froome, that research that you had originally started, I think, in about 2014. Okay, so we're going to move over to questions. So I see that there are a couple of questions in the Q&A already. So if anybody has any additional questions, please put them in the Q&A so we can ensure everybody can hear the answers. So I'm going to get started with the Q&A. So one person has just sort of noted, we did put some links in the chat around connecting you to websites for the different examples presented today. So if they can be included in the email, that goes out. So I'm pretty sure that that's quite feasible for us. We do have a question from Belgium in the research group in Belgium. So a study by Leonardo reports a decrease in transitivity between involved caregivers when social support networks increase. Is this something the speakers recognize in their respective projects? Would anybody like to speak to that? Or if you need clarification, Bert, maybe you can unmute yourself just in case. So speakers, can anyone speak to that? Or Bert, do you want to maybe clarify?
I'd like to know what transitivity means.
Yeah, I was going to ask the same thing.
So Echo Team, can we unmute Bert, or can he unmute himself? So maybe he could join the conversation.
Yeah, so now I can speak.
Perfect.
I muted myself. I couldn't speak
Great.
before. So this is a study by Leonard from Australia, I believe, and it reports that the social networks, and especially the family carers involved in the social networks, they report when the social networks increase, that there is a loss of balance of reciprocity between the carers and the increased social networks. So I'm just wondering if this is something the speakers recognize when the social networks increase, that there is a decrease in connectivity between the people involved.
I think it'd be fair to say, you know, we know from Libby Salno's research that from her PhD that reciprocity is absolutely a key issue, and Bessel van der Kolk talks about it as well. And I think that that this is a kind of goes to the question about volunteers. You know, we think volunteers are doing something for people, but in fact, when you talk to people about what's going on, that there is this really significant bit of everyone gets something out of it.
Mhm.
And so it's in a way comes back to what I was saying. It's one human being to another, and it's trying to shift away from thinking about the professional role or the volunteer role, or just saying actually the most important bit is the kindness, the love, the affection, the warmth, the relationship between people and place, that interconnectivity. That's the thing that makes the biggest difference. And it's quite hard to get this across in the context of, you know, we come from a healthcare background, but the impact of that stuff is much more powerful than anything else we can do. You know, how many of you have had your blood pressure checked when you've been to the doctor? And how many of you have had your social relationships checked? What Camilla is doing in Colombia and the US is incredible, because she's systematically introduced a system where people have their loneliness measured. And not just that, there's an action that comes from that embedded in the primary care unit. If we were really scientific, we'd forget about blood pressure and measure people's loneliness. And I think it's recognizing that the therapeutic impact of that is way more powerful than anything else we can do.
Thank you, Julian. Great. I will just jump in quick to say, because I've been focused on compassionate workplaces and read an awesome Harvard Business Review article that talked about the business case for focusing on increasing compassion. And one of the things that was said is that, you know, managers, leaders showing compassion to their employees, yes, is great, but that they themselves will reap a lot of benefit from just being able to do that act, right? To show that person compassion. So that very much speaks to what you're sort of saying, Julian. So thank you.
So I'll just weigh in a little bit on Bert's comment on transitivity. I'm not sure I understand it, Bert. But I think our data from the Nav-CARE project, and it's mostly qualitative. So, you know, when we have a family caregiver involved, we always have a couple of qualitative interviews in terms of, you know, the impact. How did this affect, you know, their lives and their relationships? And the feedback that we get fairly consistently is that there's actually less emotional intensity in the caregiving relationship when a volunteer gets involved. So, you know, they talk very practically about being the person who listens to the illness narrative over and over again, day after day. And so then when the volunteer becomes involved, there's another person to listen to that illness narrative and to be sort of and hospice volunteers know this very well. You're that special friend that doesn't have to be there. You're not obligated to be there. But there's that relationship that develops where you do hear the story and you honor that story on a daily basis. And most of our family caregivers have mentioned that that's almost a form of emotional respite for them. And so again, mostly on qualitative, we've not measured that, but that has been fairly consistent across our findings.
Thank you, Barb. Anybody else? Okay. I think we will move on to another question that we had. One is from Robert. He asked, do your home volunteers in the Nav-CARE program go through a selection process? So police checks, looking at sustainability. So Barb, I think that one's for you.
Yeah, thank you for that question. So Robert, in the early days of the studies, we did very, very strong sort of checks. So they were typically people that somebody in the organization knew. so that we had their, some background. There were certainly criminal record checks were required, references were required, and very often an interview. As we've moved to make Nav-CARE a little bit bigger and we're working through multiple organizations now, we really rely on the organization procedures in implementing Nav-CARE. So we assume that they have an organizational structure in the ways that they manage volunteers. And in my experience, many of them have very good screening processes for taking on volunteers. And so we do really rely upon that expertise that they have. Do you want me to go on to the next question? How many volunteers do you aim to have per coordinator? Now that will really depend on the number of hours that coordinator is working. And so I would say, really fluctuates. I would say probably a reasonable amount for a volunteer coordinator would probably be 10 to 12 volunteers. Yeah, because they are doing sort of an intensive service.
So Barb, you actually have another question about Nav-CARE below if you can see it.
Yeah, how do you handle the challenge of volunteers and not connecting with clients? And what is the ballpark of the minimum funding to required? Okay, so for those of you that are not following the Q&A, how do you handle the challenge of volunteers not connecting with their clients? There's always, well, two things. One is we find coordinators are extremely skilled at assessing clients and matching them to volunteers. There's somebody talked about a secret sauce here, and I swear there's a secret sauce with experienced volunteer coordinators because they just seem to know that temperament mix that's going to work out well between clients. But there's always the option, and I think when a relationship doesn't flow, it usually happens fairly early on. And so the coordinators tend to stay very connected to that pair. And if it's not working, there's no problem. They can try a new volunteer, establish a new relationship. And so there's always the expectation that that could indeed occur, and that's fine. The second part of the question is, what is the ballpark of the minimum funding required to set up Nav-CARE in a community? It's a really tough question because it depends on how big you want to grow your program and what's your capacity already. And so I would say, for an average community that's wanting to, and we do recommend you start small, you're not aiming for a big program right away. And I would say a couple days a week is a good start. Somebody working maybe 0.3 FTE, just to kind of do the groundwork in terms of educating the public around what this is, helping to get the volunteers up and running, and then monitoring them. And of course, where you grow your program from there is up to you. And the bigger it gets, the more volunteer coordinator support you're going to need. And I can't tell you how important those volunteer coordinators are. They really are the backbone of whether the program flies or not.
Thank you, Barb. So we do have another quick question, but I just want to jump off those last few, Barb, that you answered for us. I guess the question becomes about sustainability of this work, right? And so, when you guys are designing your programs, obviously you're thinking about sustainability, like what are the hopes for the different approaches that have been taken here? So maybe Barb, you want to answer that next, and then Jesse and Camilla could chime in.
Yeah, you bet. So of course, our hope is always that it will be sustainable, and keeping in mind that these programs already have volunteer coordinators. So they always have another stream of volunteers that are maybe performing a more traditional hospice role. And so at the end of the day, that sustainability can be one of two ways. Either the Nav-CARE program can be folded into your regular volunteer responsibilities, because some of the challenge is getting it set up initially. Right. So you can, some of the programs we've talked to, they put the training together. They have a single coordinator sort of over both streams of volunteers. So that's one way. Another way is it's actually a really fundable program. And, not-for-profits know this. Anytime you have a new idea and you want to try something different with it, it's really a good way to get some funding from foundations. And so we've had different groups kind of adapt Nav-CARE in different ways. And because they're doing an adaptation, it's fundable for a period of time through foundations. And so many that we work with are incredibly clever about, launching the next phase and asking the next question.
Awesome. Thank you. Jesse. thinking about sustainability? How have you guys sort of thought about it or
Oh,
tried to weave it in?
Such an easy question, Bonnie, honestly.
Oh,
Yeah, look, it's critical. I mean, you know, when the chips are down and it's late at night and you're like, sustainability, you know, my go-to is Snowflake community organizing model. And if you haven't heard of that, I encourage people to just Google it. And it's just because you'll get a visual representation of it. But it's always about looking for that, you know, that trim tab. Trim tab is like, you got a big ship, you got a big rudder. The trim tab is the little rudder that moves the big rudder that moves the big ship. So in this context, the trim tab is often an individual, a passionate individual who wants to get on with things, do things. And it's our job who, you know, when we have organizations and available assets to us, to, is what Peter Kenyon in Australia talks about, open the doors and windows for these people. You know, what windows need to be opened, what doors need to be opened. So I come back to that Snowflake model of organizing quite often when I feel like we're kind of losing our way a little bit. Also, to Barb's point about philanthropy, in Australia, only 1% of philanthropy actually goes into the pointy end of aging and death care, which is insane. So there's this massive opportunity in Australia with our philanthropy dollar. And it's also why I'm really excited about the community foundation model. Community foundations, there are 44 of them across the country in Australia, where it's all about that bottom-up grassroots giving. And we know, you know, giving is down in Australia by 30% because of COVID and the financial markets. So, but because of COVID, it's taught us, you know, we all have a role, we can all play a role in giving. And so that community foundation model, I think, is beautifully placed to support local community connector programs. Because also, you know, what are you left with when your loved one dies? You're left with, hopefully, gratitude and love. And you want to pay that forward. And that's why I think philanthropy can be a really nice fit. There's also just a lot of freedom when it comes to the philanthropy dollar. So those are my top of mind thoughts.
Awesome. Thank you. Camilla, did you want to share anything around, you know, certainly what you guys have thought about for sustainability for your program?
Well, on the one hand, we find that we work in sustainability in two ways. One, within the healthcare sector, so that we make sure that people are still, you know, doing that identification and connection of the needs and the resources that are on the ground, which include identifying and training connectors. And so the way we've done that is, you know, measuring and showing the impact it has in cost reduction effects. And so I don't do it for that, but I also understand that if I want to talk to the corporate world, I have to speak their language. And so the reason, so we started with a pilot project with someone who, you know, sort of decided to gamble it with us. And then now we have results that show the impacts and the cost reduction when you actually manage to understand. Just as a general number, when we did the first run of our surveys around loneliness, we found that every patient that scored lonely in our surveys versus those that didn't score lonely, so that's sort of the baseline, those patients that scored lonely costed 50% more than the ones that that weren't lonely in the scale. And so that gave us sort of a first push in terms of how to sell it, and to sell them that it makes sense to have community health workers that are constantly working with the connections in the community. I would say for us, the struggle in terms of sustainability, and that's kind of easy to do. You just have to show the numbers, but it's something that you can do. And there's a ton of research right now. Julian has done it, and Julian Holt-Lundstad has it too, that, you know, allows you to sell that point. I would say that on the other side, the struggle has been that we do all of the things that we do on the ground at the community level that we do with people that are willing to do it voluntarily. And so we have to choose those volunteers really wisely. We try to choose volunteers that, well, a wider number of volunteers per community, not just one that leads the whole strategy, so that if one gets tired and sort of starts dropping the towel, we have other backups. And then we also try to use different ages within that, so that, you know, sometimes, well, you know, older people sometimes say they don't want to do it anymore. And so we have sort of that change of generation as well.
Awesome. Thank you. Jesse, I'll knock one of the questions off quickly. I think you mentioned something about the Snowflake model. Is that correct? Because that was one of the questions.
Yeah. It's back in the 60s, civil unrest, America, it was about sort of grassroots political engagement. And I believe it was used to get Obama into power. So it's a model that I think we can, that's the short version. But I think it's a model that we can draw on because it taps into the small L community leadership.
Great.
Right. This
So it's called the snowflake.
Passion. Yeah.
Yep. Awesome. Thank you. Robert has another question here. So several guests mentioned engagement with the healthcare professionals, gaining acknowledgement of the value of this type of program. Any suggestions or experiences that the presenters would like to share?
I can share a little bit about that one if you want. So as I just pointed out, I would say one of the things is showing the impact in terms of outcomes and, you know, how it has worked and what impact it might have. The other thing that we have done a lot is make it personal. And so we have been recording a lot of testimonials and getting a lot of stories from the people. And so it becomes something that they can connect to. And it becomes something, so because many times it would be like, so why do I have to do this? And if he's lonely, then what can I do? And I was like, well, when you actually identify that they're lonely, something will happen because a community health worker, a connector, a community will, you know, welcome them. And so in that sense, we've started picking up stories that have worked together and the impact that it has had on them, and we bring it back to the medical centers and we bring it back to the doctors and to the nurses so that it becomes personal. So there's a number associated to what they do clinically, and so look at how this is reduced. He's hospitalized 3 times less than last year, but then we also show them, you know, that personal story with like a face and a name, and that connects them more.
Thank you. We only have a few minutes left, but Jesse or Barb, would you guys like to jump in on that one?
Yeah, just a really quick comment from me. You know, whenever we go in with health partners, you know, we always align the program to the state-based palliative care strategy. So it's about downloading those documents, reading through, and actually just reading between the lines, and then, you know, coming up with a really good case that matches. We've got to make it easy for our health systems to say yes, and that's one way to do it.
Yeah, I agree. I mean, there are so many good palliative champions across Canada, and it is trying to make it easy for them. You know, we have one really stellar health region that I know of that actually, you know, beyond Nav-CARE, really just decided that they were going to bring volunteers into the circle of care, full stop. And so they connected them. They won a quality and safety award for doing so. And when those kind of connections happen and the volunteers are assumed to be part of the circle of care and policy is changed to reflect that, then some of these programs become easy entry points. But prior to that, I think it is a bit of an uphill struggle.
Great, thank you. Okay, guys, that is the end of the questions. I see Cynthia here, who must be a part of the Nav-CARE program, just did mention that they do presentations to managers in the healthcare services, so like managers of the home care workers, as well as nurses. So that's sort of a way to engage as well. Okay, just want to go through a couple of quick slides and then we will let everybody go. Maybe Jesse can go back to bed and have a little nap. So if you'd like to become a member of PHPCI, of course, we'd love to have you. And really, it's about these sort of webinars. It's about bringing together research. It's about growing the list of resources that are out there to support, you know, compassionate community initiatives and other initiatives in the space. And then certainly the conference as well. Next slide, please. I'd also like to mention the World Hospice Palliative Care Day this year's focus is on compassionate community. So on October 14th this year, we will be focusing on compassionate communities. And so PHPCI is working with World Hospice Palliative Care Association. And so our day will be on November 1st. So keep an eye out. You may see a bunch of activities and information circulating around between October 14th and November 1st. Next slide, please. And just sort of want to mention that the next Public Health Palliative Care Conference will be in Bern, Switzerland. So the dates are, as you can see, October 22nd to the 25th. So keep an eye out for that. Excited. And that's number 8. So that's 16 years that PHPCI clearly has been working at fostering this work around the world. Next slide, please. And that's it, everybody. So thank you for joining us today. Thank you to the presenters and for them indulging me in my many emails trying to get everything organized. And as you can see here, we will be sending out a feedback survey at the end of this session. And it'll be placed in the chat, I think, as well. And what we will do is that email that goes out with the link to the recording and the slide deck, we will put some of the information so you can connect easily with the different organizations that presented with us today. And I think that's it. Last slide, please. Yes. All right. Thank you, everybody. Have a wonderful day and hope to see you guys soon.
Thank
Thanks,
you.
Bob.
everyone.
Bye.
Bye.
Bye, Bob.